On behalf of IAP technical team, I welcome to all attendees and all panelists. Before hand over this webinar to Dr. Punima ma'am, I request to all participants please subscribe our own IAP YouTube channel for watching and knowing, learning more and more knowledge. Our today's moderator is Dr. Punima ma'am. She is currently working as a physiotherapist specialist at HMC Doha, quartered since last 2 years. Previously worked as an assistant professor at SDM Physiotherapy College. Thank you so much, ma'am. Now I hand over to you. Thank you.
Unmute.
A very good evening to one and all the panelists and the participants. I will heartily welcome you all for this wonderful webinar where IAP Women's Cell jointly with TN Forces is organizing this webinar for the physiotherapists on this event of World Breastfeeding Week. We know that there are a lot of webinars going on this topic. The question comes is why physiotherapist is linked to breastfeeding. It so happens that in our journey of treating postpartum women, we have seen that they have been struggling a lot through lactation, through breastfeeding, because that is the initial phase. And there we are bedside trying to assist them with exercises. That is when I feel the physiotherapist started acting as a bridge to help the lady help in lactate, so that once she is successful in this phase, the mother can focus later on other musculoskeletal issues. So I have been personally working also with these women for more than 15 years, where I have understood that we have a great role. We are an enzyme to this process. And we have great speakers today, eminent speakers in their own field, who will be enlightening us with their topics. I would just like to start with a quote, which I really like. It is by Iris Young. He says, "Show me how to lactate and I can be the best mother a father could be." So he's relating to the effect of lactation so much so that it impacts the infant to be a better child later. And in line with the WHO and UNICEF theme, where it says support breastfeeding for a healthier planet. So let's start this webinar, and I welcome all the panelists once again. We start with our first talk on IMA Act, which will be dealt by Dr. K. Shanmuga Velayudam. He is a practicing advocate in Madras High Court with educational qualification of MA, MPhil, and PhD in social work, and BL, MA for psychology, MBA, and MEd. He is a member of RCI, and he is the convener of Child's Right Network Organization, namely TN Forces. For Tamil Nadu, and he is also a managing trustee for You Child Rights based organization. We welcome you, sir. Over to you. Sir, unmute yourself. You have unmute.
Okay. Thank you very much for the opportunity is given. It is a good opportunity for us. At least we can disseminate our information to physiotherapists. Really, it's a good opportunity for us, because law is also a very important aspect for the physiotherapists, because in our constitution, in our country, rule of the law is a prime. Whole thing is based on the law, legal aspect, rules and regulations. In that context, at least physiotherapists should know about that. There is also in a legal maximum, ignorance of the law is no excuse, because I don't know the law. You cannot escape from that. Every individual should know the law. As a citizen, you should know it. In that context only, see, I am explaining brief aspect about IMS Act. Now I will go through it.
If any participants have any doubts, they can write down in a chat box. At the end of the session, we will discuss your doubts. Thank you.
That is the title of the act itself is a infant milk substitute feeding bottles and infant foods. That is a regulation of production, supply and distribution act 1992. Original act is the 1992. Again, keep in mind regarding from 4 months to 6 months exclusive breastfeeding, and also 2 years, below 2 years, there's no need to give a infant food. For that only they have given amendment in 2003. So in that aspect, it is a brief about that what is the Act, IMS Act 1992, amended in 2003. About that aspect, we can think.
So sorry
Okay.
to interrupt.
Ah,
Can you
ah.
make it full screen, sir? Your
Yes,
PPT.
yes, yes. Now,
Okay, thank you.
okay. Now, already Purnima Jain has mentioned about the theme for the year is a support breastfeeding for a healthier planet. So you may wonder regarding what is the relationship between a healthier planet and breastfeeding? Because breastfeeding is a sustainable way to feed our infants and young children and provides a food security for them in emergency, climate change, even a COVID condition also. So that is why it is a sustainable way we can provide the food. Same manner, breast milk is a natural, renewable food that is produced and delivered to the consumer without any pollution. There is no adulteration at all. Even a package and wastage, there is no such pollution. So when we protect and support mothers and breastfeeding, we are also reducing the carbon. That's called a greenhouse, and air pollution, water pollution, land pollution. So all the things we have to protect them. So that's why World Alliance for Breastfeeding, they have given this theme. Indirectly, it helps a healthier planet. We should also, as all physiotherapist members and other things, one way to protect the earth is that we should support breastfeeding. Now coming to the Act. Act says regarding it is a prohibit any kind of promotion of infant food. The word promotion is a very important thing. Again, second aspect is concerned educate pregnant women and lactating mother. It is also one way to educate them. What are the things you need that? Then restrict and control use of infant milk substitute. That is a below 6 months. What is the infant milk substitute? This is called artificial or infant food. All that thing, it is not completely banning, prohibiting infant milk substitute. It's regulate and also control. Certain extent control is there. That's the most important aspect because in the human population, there are certain percentage, very minute percentage, they cannot digest the breast milk. They need because of the metabolism. They need infant milk substitute. For that only they have given only regulation. Same manner, in Act they have prescribed about the role and responsibility of healthcare institutions and health worker. What is the role? What should do and what should not do it? That is also they given. Now, under the Act Section 3, I already mentioned it. It burns a promotion, advertisement to the public. Is a print media, visual media, cable network, all the things. It is a prohibited. Advertisement is a prohibited. If you come across any company, any person advertising, promoting these products in any manner, you can notify it to agencies. There are agencies available there. It is a grievance redressal mechanism. You can also submit. Then again, prohibits giving incentives. Suppose in the name of infant milk substitute or infant food or even a feeding bottle, sometime what happened, they may give free sample, gifts, tide sales, discount. In any way, these products, it is also prohibits. You should not have any incentive for that. That is also they given. You can report to these notified agencies. Then again, restrict the donation of products, educational materials, or equipments. If you come across any company distributing baby food, educational material, equipment to mother or a health worker or medical people, that is also prohibited. Then again, in the package or in the tin or in the box, there are things, prescribed guidelines for labeling. What should be there? If you come across any label not according to the IMS Act, or it has a picture of a mother and a child, or any graphic material, bird or teddy bear, cartoon, etc., that is, they may claim regarding this is equally is a good. It's a motherly affection. All the things is a prohibited. You should not put in a label in the box. Same manner, it also ensure actual information through accurate information through educational material. What is the thing means? So in that box or in that label, Mother's milk, breast milk is important. Breast milk is the best. In that manner, they also should give that. Same manner, what are the content of that infant food or infant milk substitute? What are the harmful effect of that? When it was packaged each, what is the MRP price? All that thing should be there in that package. That is also there. Burns promotion and display in a hospital. Any hospital, clinic, chemist shops, or any provision store, whatever may be any promotion, they put the poster or banner. Even they can put the showcase. No, if you go there in medical shop, what happened? The showcase, what happened? Three things prominently they have put it. One is called the infant milk substitute or infant food. Another thing is the napkin. All the things they put it. As far as the infant food and infant milk substitute, if they put it in a showcase in the gallery, that is a punishable offense. That's the way they will promote them, the product. That is also offense. Then bans a direct or indirect benefits to health worker. Suppose example, they give a sponsorship, they give some sort of sponsoring program, lunch or dinner or some sort of tour program to the any health. Nowadays, there is an infant milk substitute, infant food. There is a multinational company, innumerable multinational company, including Abbott, the Nestle. They may have lot of products. See what they will do, they, among the products itself, there is a competition. So in that competition, what happened? They promote these in a unethical way, and they do all sorts of things for that. That is also one aspect. It is also prohibited. Burn on commission on a sale. Suppose example, if the sale is so much, if you have 10% or 20%, that is also wrong thing. Any violation, all I mentioned, no promotion, advertisement, commission, even sponsoring a seminar, it is a violation of the act. That's called penalty. There is a from 6 months to 3 year imprisonment. There is also a fine up to 2,000 to 5,000. That is also fine. Both can possibly serve. Uh, then no advertisement is a baby food in the print media. No advertisement in the TV, cable TV, radio, network, all that thing. Free gift to promotion, infant food, that is a ban. Then again, no promotional activity like a scratch card, incentive, gift, and other thing, that is also banned, prohibited. Promotion a health system through display violation, that is also prohibited. Reaching the mothers through pamphlet distribution, that is also violation. There is also district level monitor for violation of IMS Act. There is a structure in a state level, district level. There is a you can register a complaint. Any violation of that you can complain. Public should be informed through advertisement. That is these are all things. Even among the Indian Association of Physiotherapists, you can also promote these type of things, because the baby food companies and the allies should not be allowed to conduct meetings, workshop for educational, medical, or nursing personnel. Regular checks on chemist shops. As a physiotherapist, when you go there, you check whether they have put it in a front portion, whether they display it. In case any display, you take a snap. You can take a mobile phone, and then you get informed to the thing. As for the national level, there is an organization called Breastfeeding Promotion Network of India. They are the recognized agency for monitor that. Again, you can also create a awareness. You can put your hoardings, the places to generate awareness. Because one of the problem for this, even in India, there is a National Family Health Survey. They assess regarding what is the pattern of breastfeeding. Even now, even advanced state, whatever may be the state, even we are not able to achieve some of the countries like Sri Lanka, Sweden, all other places. Why? That is because of the infiltration, because of that undue promotion of the multinational company, especially infant food. That is why even here there are states where having a 99% of institutional delivery. On the other hand, within a 1 hour, initial breastfeeding is concerned not even a 50%. Why? Same manner, exclusive breastfeeding around only 40-60% only, most of the state. Why is happening there? Because of that, that is a infant milk, that artificial milk that has even enrolled into that mothers. There are also people tell them mothers they are not able to secrete the milk. We are not able to give them. That's not sufficient. Lot of myth also available there. It is our duty to promote and defend and also protect our thing. Suppose example, recently I received invitation from OGSSI, or the Obstetrics and Gynecology Society of Southern India. Actually, tomorrow is a program. So I made a complaint to the Director of Public Health. They got a sponsorship from About India. About India is one of the US based company, where that the webinar program is based on breast milk, breastfeeding promotion. There are a lot of panelists. Now I have protested it. I sent a letter to them. Definitely, I am going to the court regarding that. Even now, they have changed that sponsor. Even then, also already they have sent invitation through them. They are giving About India Private Limited sponsor. This is a MNC company. See what happened. All the products, if you see there are innumerable products. You should know about the infant milk substitute products. Are all variety of products. Same manner another. Yesterday this is a program. ECME organized with Abbott in collaboration with the HARM, that is Obstetrics and Gynecology Society. This is also about this type of promotion. It's unhealthy. As far as the IMS Act is concerned, blatantly violation. If I complain to this notifying authority, they can take action. I request the physiotherapist thing, before attending any program or anything, you check whether it is sponsored by this type of multinational company, where they may not say openly. They put the company Nestle, about there are like Amul spray, all that thing, because they're very clever. They catch hold of some of the medical people. One of the culprit for our promotion of artificial milk is concerned, these medical people. One aspect is that they are not aware about the act, implication of the act. Already mentioned regarding that. There is both imprisonment and fine. There are a lot of cases there available there. As a physiotherapist, I request you should know about the IMS Act, and you should propagate that the essence of the command. You should also not involve in the breast milk. As you all know, regarding breast milk is one of the important first immunity to the child. So in that context, I request Physiotherapists Association, IAP, Indian Association of Physiotherapists, to propagate, to promote, and defend the breast milk, breastfeeding. Thank you very much for the opportunity. Anyone can ask question, you can.
Thank you very much, sir. It was really a much needed presentation for that, because we all know that breast milk is important and how much it is the wholesome nutrition for the baby. But we also see that it may not be, we may not see a direct advertisement, but still there is some kind of indirect advertisements to these artificial foods. It may be through the pediatricians where the mother visits, or it may be through the neighbors where they feel that breast, because the point is we don't see the amount of breast milk being fed. So what mother likes to see is, when you're feeding through bottle, when you're giving an artificial feed, it is through she can measure. So she feels that her baby is growing much better with bottle feed or top feed rather than breast milk. But as physiotherapists, we can assure you, sir, because here our motive here is to be with the mothers to promote breastfeeding. So indirectly, we are supporting this, or maybe we are promoting the breastfeed so much that we are stopping the use of top feeds. So in this way, we are indirectly helping you. We may not be fighting with against any multinational companies, but by educating these mothers to go for breastfeeding, we are supporting the same theme. Thank you, sir. I think
Thank
I
you.
don't see. Sir, I would like to have a question for you. We know that BPNI is also working relentlessly every year for the same cause. What is your observation that how much of change we are able to bring in through these current years? We know that significantly the advertisements have dropped, but still we see that the usage of the artificial feed is still continuing to be on a higher rise. So what
Now,
is your opinion?
direct promotion they are not doing, because it
Yes.
is they know about that thing. What they will do it indirectly through these medical people, medical association, through that what they will do it, they will showcasing the pharmacists there. When you go there, what is a product? I think they will indirectly they will say. Even they may not have even a medical people, doctor. I think they may not prescribe it, because they may also land in a problem. So what happened indirectly, they tell, and suppose example, if you not get enough milk, so they you can go and get these Nestle and non. There are variety, Pro non, non one, non two, non
Yes.
three. There are innumerable more than 25 products is available there. So such a type of competition. And also the cost of the infant milk substitute, starting with the 300 to 1000 rupees. That will be there for 1 week only. It's very costly affair for the children, for the family. So that's why, not only health point of view, economic perspective is concerned, we should not promote these artificial there. Somehow or other, what happened, there are psychological problem like the confidence. You need, without any stress, without the family support, all that things are important for breastfeeding. Again, I request a physiotherapist, you should help them. What are the ways to promote breastfeeding? That it's my humble request. You should do it instead of going for RTO, because there is also a problem with the nipple confusion. Once you started with the feeding bottle, they
Yes.
never go for the breast milk, because no, then that the artificial milk is concerned sweet, they like it, so very difficult to change over to breast milk. That's a problem will come. That is why again we should stress for counseling. There are lactation counselor is there. You consult them whenever any problem or other thing. That's the thing. Thank you, sir. Thank you.
Yes, sir. Thank you so much. You rightly said, because many times we see that if a mother is, if the baby is not able to put on weight, the first option comes from the pediatrician. Most of the times is maybe your breast milk is not sufficient. So here, as a mediator, as a lactation counselor or consultant, we are here. The mother just needs a little help. Many times we see that with this help, many times they have overcome the challenges and the baby is on exclusive breastfeed as advised by WHO. It is just that this phase, if this help is not there, many a times they switch over to the artificial milk. So thank you so much, sir, again for the wonderful talk. We now move over to the next speaker for today. It's Dr. Jayashree Jaykrishnan. She is an IBCLC and IYCF member, founder and director of Happy Mom, Pregnancy to Motherhood Services, Chennai. And she's a clinical physiotherapist who is working in the field of natural as well as water birthing. She's been trained and certified in spinning babies, hypnobirthing practitioner, certified donor, and the first person to introduce the concept of aquanatal sessions in Chennai. So she has presented various papers in national and international conferences related to lactation. And also she's working with research topics related to childbirth and labor. And she has assisted hospitals to set up natural and water birthing centers in Chennai. She has conducted workshops concerning lactation, labor, and childbirth. So we welcome you, Dr. Jayashree. So over to you.
Thank you, Dr. Purnima. You can see my screen? Yes. I need to thank IAP for taking this wonderful initiative. I never thought IAP was so friendly. I was always been away from them for so many years, but I feel bad for that doing so. I need to thank Dr. Ruchi for being so responsive for all the informations what I asked. So I need to thank IAP for doing this wonderful initiative from Women's Cell on bringing this World Breastfeeding Week awareness that month. We are going to talk about lactation and the role of physios in the field of lactation. So Dr. Purnima has already said that we are going to be an energizer, even I want to say as a catalyst for the moms to get along with the breastfeeding success. So my introduction has been given very well with Dr. Purnima. So going with the breast development, see, breast development is something a vital part of the women's reproduction. Breast development actually keeps changing in every stage of the women's life, right from the birth to the puberty, and later during the childbearing years also it keeps changing. Now start with from the fetus onwards, the breast starts to develop, which comes like a mammary ridge. If you see the first picture, that's a mammary ridge, and from there only we say as a milk line. And later on, it becomes a rudimentary mammary ridge. And once a baby girl is being born, the nipples and the beginning of the milk ducts have been already formed. So the first thing which the breast formation happens is the lobes. So these lobes are small division of breast tissues. The mammary glands develop next. and consists of about 15 to 24 lobes are over here. So mammary glands are actually being influenced and activated during the puberty period, and there are a lot of lactiferous ducts behind your areola. Areola is a dark region behind the nipple, and which expands and branch extensively during the pregnancy. And actually, that happens in response to the hormones, this estrogen, growth hormone, cortisol, and prolactin hormones. In response to this progesterone hormone, there's a cluster of breast alveoli and buds from the ducts over here, and from the ducts and expands outward towards the chest wall. These alveoli calls the milk secreting cells, or lactocytes we say. So from the milk secreting cells, this fills the alveoli and squeeze the ducts. So this squeezing of the milk will be gone to the lactiferous sinus, where 4 to 18 perforations are there. That perforations in the nipple only we say as nipple pores. Okay, so this areola which you see has small bumps for these lactating mothers. They'll have pimple kind of structures, and these bumps are called Montgomery glands. And as you know, these glands are being secreting oil and to cleanse the nipple for the opening and prevent the chapping and cracking of the nipple during the breastfeeding period. So coming for the physiology, I just quickly run through the physiology. There's two hormones, two major hormones being involved in the physiology. One thing is the prolactin hormone, another thing is oxytocin hormone. Prolactin hormone is actually for the establishment and for the maintenance of the breast milk supply. It happens. So usually the prolactin hormone, the level of prolactin hormone during the pregnancy period, usually very high and enough to initiate the milk production starts to happen. But due to this estrogen and progesterone and other placental hormones during the pregnancy, it doesn't happen. Only at the expulsion of the placenta, these hormones starts to drop and the milk secretion starts to happen. So how this milk secretion starts to stimulate it, every time the baby suckles, it's going to prepare for the future feeds. That's what we tell. The more the baby suckles, the more you're going to produce the milk. So slowly the prolactin hormone starts to spike, and estrogen and progesterone also slowly start to increase. But when the infant suckles, no, there's a sensory nerve fibers in the areola which goes and triggers the neuroendocrine reflex that results in the milk secretion from the lactocytes into the alveoli. So the posterior pituitary releases the oxytocin, which stimulates the myoepithelial cells to squeeze the milk out from the alveoli so that it can drain into the lactiferous. So collecting it in the lactiferous sacs, and then it gets discharged into the nipple pores. So it's to tell it in a very understandable manner. When the mother is so much in stress, no, many times they say you will not produce milk. But personal, from my experience, what I've seen is it's not about the milk production. She has milk because of a restriction in oxytocin hormone. The ejection of the milk will not happen. But in the contrary, when she's very relaxed and in the very in a lighter mood, the oxytocin production is higher in mode. So the ejection out of milk will happen. So going with the stress and milk production is actually go on this oxytocin hormone involvement, not about only about the direct indication of milk production. So coming for the breast assessment. So antenatal period itself, the breast assessment has to be done. So as the physios are rolled into starting with antenatal exercises, prenatal exercises, childbirth classes, it can be of any format for the layman to understand. The breast examination has to be part of the protocol in all hospitals. Now most of the hospital has made it as a protocol. So initially the mother has to be examined on the breast. The breast shape will be seeing those slides again. And another thing what you have to see is you have to ask from the mother whether she had gone through any surgeries like a reduction surgery or enlargement of breast surgery. You need to check out. There are mothers who tend to have fibroids. Either these fibroids are removed or sometimes the fibroids are still existing where it's not actually interrupting them. The breast surgeon should have advise them it's okay as of now, it's okay. Maybe in case during the time of feeding, if there are milk pockets are being found in the fibroid, at that point alone we can do the insertion drainage, but otherwise they don't interfere with these fibroids. So it's a duty of the physios who does the assessment to check whether there's a fibroid or cyst is there or there any kind of scars which they can look into it. It's a main key thing for the physios to be a lactation consultant is they do understand the muscle tissue. They can understand how the knots are there, whether it's a knot or it's a cyst or it's a fibroid or it's kind of a trigger points. That difference has been well recognized by a physio compared to other professionals. I feel it personally in this case. So Coming for the antenatal breast preparation, as I already told, there are different shape of breast are there. So each shape of breast is actually depends upon the weight of the mother, that is the fat which she is going to have in the breast tissue and density. And also you can see the weight of the breast actually starts to sag down because of the weight which they have in the tissues. And next thing is the posture. The rounded shoulders also add on to the sagging of the breast, which they mostly happen to see in the pregnancy period compared to the pre-pregnancy period. And the age, another thing is age also makes a major role with the changes in the breast. Mostly pre-menopausal time and the menopausal time, the connective tissue of the breast is being lost. The strength of it is being lost. That's why the involution starts to happen during that point. So pregnancy and the breastfeeding period is a major period where a lot of changes because of the proliferation of the ducts which happens, which makes the breast to have bigger in size and appearance. So once for the coming for the breast preparation, we have to tell the mothers to keep the breast very clean. That is, most of the time what they do is they keep washing the breast with soap waters, and or we should tell them not to clean with soap waters and all, because it tend to keep the nipple and nipple structures dry. And also we have to educate about the wearing of supportive braces, because braces do have its role in giving proper support. Having a braces which has an wire, this underwire braces, that do impact the lymphatic drainage. And also that also has a major reason to have a breast tenderness or a kind of a tightness in the breast. It tends to happen during the antenatal period itself. So having wearing a proper brassiere and helping them out to guide out with a proper brassiere, and the straps should be like sturdy and sufficiently wide to prevent the breast from sagging without pulling the shoulders. It's all very important. So these things has to be guided in the antenatal period by the physios regarding to the breast. So coming for the massage. So usually I tend to teach mothers breast massage for the pregnancy period right from 6 months onwards. So breast tissues usually extend all the way from the armpit and towards the this intercostal area. You can see the breast tissues over here. There are many lymph nodes in this part of the body. So massaging them actually help them to stimulate your lymphatic system. This also helps them to flush out all the toxins from your breast. And also if there's any lymph nodes which may lead to kind of fluid collection called lymphedema. So doing a massage actually helps in the lymphatic drainage. And also due to rounded shoulders during the pregnancy, you do develop a tension in the back that may be compensated by tensing your chest muscles as well. So massaging to the chest can bring up more relaxation than massaging of the back alone. So we always tend to make sure that all the mothers have been taught with breast massages. While doing breast massages, they also being instructed there are chances you can see some few drops of milk coming out. So don't get panicked. But what the thing is, this having a milk drops coming out from the breast, that some mothers tend to think only if that comes they to lactate well. If they don't find these kind of milk droplets coming out, they may be not lactating. But it doesn't have any interference in the lactation period at all. Having a milk seen during the antenatal period or not seen doesn't have an influence on the lactation at all. So now coming for the nipple, this is a random picture shown of 8 types of nipple, but we have seen some more other types. So this is called the normal nipple, everted normal nipple, they tend to say. And these are flat nipples, puffy nipples that the areola region alone will be like puffed up. And these are most commonly inverted nipples. My straight answer to this is, whatever is the shape and size of the nipple, you can still latch and position the baby. There's no interference like at all required. So no need to panic the mother like saying, oh my god, you have an inverted nipple, so you have a difficult task in breastfeeding. No, actually it's not at all required. And during the pregnancy period, your breast and nipple undergoes a lot of changes, so not required that you have to do special techniques and all. But still certain techniques are still persisting in many hospitals. But I tend to take it as a point of doing this as like a natural induction of labor. So it can be for a natural induction, but actually I feel this doesn't have a major impact for the nipple eversion at all. The main reason to have nipple eversion to happen is only when the baby suckles. The more the baby suckles, the eversion seems to be very natural. So these nipple anomalies are congenital anomalies. It's not like it happens only at the time of breastfeeding and all. It's mostly congenital. There's something called supernumerary nipples. There are this mammary ridge, as I told you in the first slide. During the mammary ridge, there are mothers tend to have extra nipples on the breast. So when they are lactating, they tend to lactate from that nipple also. This is actually something very commonly seen, but that's nothing to worry. After days goes by, it actually subsides. It doesn't have much of milk oozing out from that area. Only from the main breast, the milk starts to come. Another one is arthelia, where there's no nipple at all in the breast. And polymasteria is accessory breast is along with the milk ridge. That is, some others tend to complain after the childbirth that I can see a lump over the in the armpit like that. This either can be of over milk production, where they didn't withdraw of milk is not being done properly by the child. Otherwise, it can be because of a wrong wearing of a brazier. Maybe of these two reasons, this may occur. Otherwise, as I already told, this can be if one of the reason of polymastia, where for them this anomaly is being predominant to show it outside. Next is amastia. Amastia is no breast development at all, and last one is emacia, is nipple developed or no breast development. Any of these things. So Hoffman techniques. This is generally been taught like old man tales like this. This has been also taught. This Hoffman techniques, we tell them to hold the with the thumb and the index finger, hold it and roll it and keep it inside like this. But actually, I tend to use this only for natural induction of labor. So this I tell them only for that reason you do it. I don't talk about the nipple eversion. There's no guarantee that the nipple eversion will happen just by doing this, because at the time of your labor, you've been given with IV infusion. So IV infusion, you can see post delivery, there'll be a lot of water retention all over the body. That tends to happen even on the breast also. So when that is happening, we tend to teach them with this reverse compression pressure technique, where that they tend to that the small edematic things around the areola will get subsided, so that eversion of the nipple will be still more better. So this technique not only taught postpartum, we tend to teach them even in the prenatal period. The pregnancy period, most mothers around the nipple and areola, they tend to have dark patches, very dark patches, peeling skin, dry skin. So they've been taught to do oil massages post 37 weeks. The reason why it's been told for post 37 weeks, as I already told you, there's a reason of natural induction of labor to happen when the nipple stimulation is being done. So it's always better to start all these things post 37 weeks instead of starting prior to that. So this reverse compression technique, I tend to do it at the time of the pregnancy. So this nipple and areola structures will get softer, and all this additions will get cleared. And post delivery, this helps for the mother, so that if there's any water retention or anything, which gives them the space for the baby to latch out, so the tissues will become still more softer for the baby to latch. So okay. The next one is, as coming for the antenatal, of course, this is not required for me to tell about it. It's every physio's strength is exercises. The major things, as I already told you, for the chest muscles, it's mostly the chest and upper back stretches and strengthening needs to be required. Why the breathing part is being included in this is, during the pregnancy period, there's a lot of adjustment is being happening. So some of these changes may cause pain in the chest, and this expansion of uterus can give undue pressure on the diaphragm also. But your breast becomes larger and your rib cage also starting to widen, which cause real pressure, and possibly there seems to have pain, which may lead to shortness of breath. That's why every prenatal mother needs to taught with this intercostal breathing and abdominal breathing and diaphragmatic breathing has been taught to them. So along with that, the stretches and strengthening of the muscles also is being taught simultaneously to these mothers, so that post delivery they'll be in a comfortable position to hold the baby and feed the baby. The most challenging thing which I face with the mothers is, I'm not able to hold my baby for a longer time. I can't sit more than half an hour. My arms are paining, my wrists are aching, my low back is paining. This is the most important challenge it's facing. It's not like they don't have an intention to breastfeed. Everyone has the intention of to breastfeed. Only because of physical ailment, they're not able to do so. So done, yeah, finished with the antenatal. Now comes with the childbirth period. So during the labor, I feel all physios needs to take up this thing of labor exercise specialist. I feel their role is like immense. The gynecologists whomever I'm working, they understand now the physio role at the time of labor, childbirth is so important. They change the scenario. by teaching certain positions, by helping the mother to open the outlet, changing of the position at the time of labor. It gives a very fast labor. They tend to have more vaginal births. C-section rates have come down. So having physios round the clock in the hospital and assisting all the mothers during the labor is a main key thing for the maternity hospital to get very famous. This is one key which I feel the gynecs will come up to know as years to come. The hospital whichever I'm working with, they started to analyze that, and now they're keeping their nurses or physios to be a part of the birth assistants. So those who are being as a birth assistants, make sure that you assist a mother immediately after delivery. The baby has to be onto the breast. The reason of early initiation of breastfeeding is the one thing is the immediate attachment and bonding of the baby. First thing is it helps the baby to suckle in the first manner. First thing. Next thing is it acts as a first vaccine to the baby. And next thing, the more the baby suckles, there's an easy expulsion of placenta. Now the Lakshya guidelines, the government guidelines have come up. You have to wait for the placenta to expel on its own. There shouldn't be a manual extraction of the placenta. So to have the placenta to expel on its own, the first key is put the baby onto the breast. So as the baby starts to suckle, the placenta will expel on its own. And next thing is, most of the time there'll be long time labors for both mother and baby. When you're missing that first feed within 1 hour of the child's birth, if you miss your that first feed, no, both of them will start to go for a very long nap. That will be another reason for the baby to go with hypoglycemia, or they may go with jaundice in the later days, or the baby is not sucking consistently. So make sure all babies are being immediately breastfed. At least within 1 hour of the childbirth, the baby has to be breastfed. Another thing is no clamping of the cord. The clamping of the cord is not by law has been given. WHO has given a guidelines of 2 minutes you can wait, but in Indian guidelines they have given you can wait till the placenta expels and then you can cut the cord. We had waited really about 6 hours. My own childbirth, I waited for 4 days to clamp my cord because I took an option of lotus birth. Lotus birth is letting the cord to come out on its own. So with that option, I wanted my baby to have all the nutrients from the placenta. So which is another aspect which some mothers are also trying to do it. So coming for the position, there are various positions the mother wants to learn into it. The first thing is a well-known thing is the cradle hold, and this one is a football hold. The football hold, the reason is they tend to keep the balls near the armpits and they carry. That's why they got with this term. And this one is a cross cradle hold and lying position. And this is a laid back position. See, every position the mother needs to know it. There's no standard rule that the mother needs to know only one position. Every mother has its own way of comfort, which may keep changing. And keeping one position round the clock all the time will have its own cons actually. So coming for the cradle hold. Sorry. So coming for the cradle hold, the main drawback is they tend to droop forward. They tend to bend the neck forward. Automatically, when they do that, the baby comes to the flexion position. Generally, I tend to tell to all mothers, when you eat food, you don't put your head down. You don't flex your neck and put your foot inside. You eventually tend to put your neck behind. An extension of the neck automatically happens to put your foot inside. So that there's the lower jaw drops really well so that you can have a wider mouth to have the food inside. But in case of a baby alone, we tend to put the neck in flexion. When the neck goes in flexion and then to put the head inside the baby's mouth, what happens is the baby can't able to intake this areola inside. The areola intake has to be asymmetrical. It shouldn't be a complete areola. Each mother's areola size is different. You can't say that you have to put almost all the areola inside. It should be asymmetrical, means upper part of the areola has to be visible. The lower portion of the areola has to be inside the baby's mouth, at least 3/4 of it. So when they are doing with this cradle position, most of the mothers, I have to tell, at least 80% of the mothers get to a problem of nipple pain. Otherwise, they are landing up in the neonatal physiological jaundice. Later, they go with the dehydration. This will be landing up later in the reason of failure to thrive and go with the formula feeding. So what we did is we started to go with more of cross cradle position in the first 20 to 30 days at least, the second picture. When this going with the cross cradle position, the mother has a very good grip on her hands. So when she's holding it, she can cover a maximum portion of the areola inside the baby's mouth. If you see, the baby neck is already into extension. So automatically the lower jaw opens. And once the jaw opens up, the mother has enough space to put the areola inside the baby's mouth. It's usually baby to the breast, not breast to the baby. So don't bring the mother to the baby. The mother has to be in her position, only the baby has to come to the mother's position. So the next thing what you have to see is the latch. Once you place the baby, the latch I was telling you, most mothers get convinced by the sucking of the baby. They think baby is getting milk, baby is sucking, consistently sucking, you should be getting milk. This is a thought what all mothers receive. But eventually by third day, there's a weight loss, 10% more weight loss is happening. Then the pediatric gets tensed and they said you have to start with the formula. But once we check, it will be like the baby will be nipple feeding. So nipple feeding, the main drawback of nipple feeding is they do get milk, but they do get it in a very minimal droplets, which will not be sufficient for the baby. And even though they feed also, the baby will not thrive. But in case of this picture, this asymmetrical latch picture, the baby able to intake major portion of the areola, so that where the lactiferous sinus is there, each suck they could withdraw a maximum amount of milk. So that's why if a baby is 3 kg, we are able to see the babies doubling in weight in 3 months itself compared to the earlier days. So earlier days, usually they get doubled in 6 months, either 5 to 6 months. But all my babies who are doing this cross cradle, they're able to double the weight in 3 months. Sometimes it happens in 2.5 months itself, because the mother is always on feed. 24 hours, mostly like on feed. Babies will not open the eyes and feed. Most of the time they close the eyes and feed. This has to be taught. Actually, the baby sleep while feeding itself, not required they have to sleep separately on the bed. 16 hours, 18 hours of sleep pattern will happen when they are breastfeeding itself, not like separately on the bed. They may sleep on the bed occasionally, like 1 hour, 2 hours, or in 24 hours, only for 3 hours they may sleep, but not at a stretch they will sleep. So when they're going with the feeding position, the most important challenge is sitting posture. I think even I'm not sitting properly now because of my laptop placement. But usually this is the sitting posture every mother needs to be taught. So as I was already telling you, with this posture, the main issues I was telling for the cradle holders, they tend to easily get with neck pain, upper back pain, low back pain, and slowly they start to droop forward, and that goes with hip flexors, and then later goes with your calf muscles, and then goes with your ankle. To say honestly, whole body will be aching. She'll be just waiting for a time that I could leave the baby somewhere and go and lie down at one place. So we thought the cross cradle hold will be very comfortable, because anyway she's taking complete back rest. The baby will be coming to the breast, so she'll be comfortable. But still, there also we had a problem. The problem is, if you see, can you see the wrist? She's holding the wrist like this. How long she can hold the wrist? Obviously, she'll land up with decuance very soon. Either she may go with carpal tunnel. Any of this problem comes very easily. So immediately we have to give a quick bandage. For temporary recovery, we have to give something so that she continues. But ultimately, they need to be taught to do the upper body exercises on a regular basis post delivery also. This has to be included as they are feeding the baby also. Post delivery exercises also has to be done. When we say post delivery, everyone's mind goes only for pelvic. Other than pelvic, the upper body is being forgotten. They need to be taught with the chest muscle. They have to be taught with the shoulder, neck, wrist, fingers. These to be taught. Because this challenge, what happened, many mothers tend to say, I tend to find tingling sensation. I'm not able to hold at all. They tend to droop the baby forward. When the baby comes drooping forward, ultimately they go with nipple feeding. Again, the same problem comes with nipple pain or any kind of engorgement or abscess. So other postures, what we have seen the first one, cradle, cross cradle, and next is this football. Football works wonderful for many mothers. For C-section mothers, it works. But again, the same problem of wrist pain comes. So ultimately, they need to be taught with either with the cross cradle, this one. But cradle, I always try to tell them, try to just give some more days to switch over to cradle before going with the other positions. Then lying down, I personally don't go with lying down for the first 3 months. I tell them to start after 3 months, because the mother is not sure with the latching and position. There are very high chances the baby can go with the nipple feeding. There are chances of sits happening or sometimes nose block happening. So it's always better to sit and feed for the first 3 months. And laid back feeding is something very relaxed position feeding. For this relaxed position feeding, the mother needs to be confident. Many mothers doesn't want to do that. It's more a fear whether the baby is feeding or not. So this happens only if the baby is like 5 months, 6 months period of time. But after 4-5 months, there's no role of LC. That is, there's no role of lactation consultant at all. It's only the baby's way. The baby will be going all 360 degrees to latch onto the breast. So no, not required that the baby has to be in this position, the latch should be in this position. No guidance at all is required. The initial window of guidance is only from the time the baby is born to the first 3 to 4 months. Later on, there's no exact guidance of position, hold, not at all required. I just give it to the way the mother and baby wants. So I explain this posture. As I was already telling about the carpal tunnel syndrome, upper back and low back pain, and generally when they tend to sit and feed, we tell them to have a complete back support, support your foot like this. But eventually, as a human being, you can't sit in this for more than 20 or 30 minutes. Eventually, you have to change your posture. Even though whatever comfort you do, also you need to change with the next posture. That's the way you can go ahead. So it's better to teach 2 or 3 more positions which help the mother to change at the time of a breastfeeding journey. It's not one particular posture, we have to stick on to it. So the common problems if the baby is not being latched properly is, first thing is they may come up with the pain, nipple soreness. So nipple pain, nipple soreness, the first straight answer is correct the latch in position. If the latch has been corrected, there won't be pain at all. Even mothers who had peeled the skin who came to us also have breastfed really well post correcting the latch. But in case still they are doing the nipple feeding, they may land up in breast engorgement. For breast engorgement, the best thing to do a quick recovery is put the baby onto the high couch, like bed which is, or a desk which is higher in height. Put the baby over there, lie down over the baby. So let the gravity helps to drain out the milk. Either that way. In that case, if the baby is not able to drink completely, we tell the mother to apply cabbage layers. The layers of the cabbage can be wrapped around the breast. There's no scientific proof till now why cabbage is helping out. But many years that's been helping in reducing the engorgement. After that, if still it's not resolving, we tell the mother to hand express. Some mothers doing pumping at this point may aggravate with the nipple pain and nipple plaque, because when doing a pumping, there are the skin tissues are getting still more stretched out. So most mothers will say, when I pumped only, I tend to feel my crack is getting aggravated. I started to bleed. So whenever they're getting engorgement or a kind of nipple pain, please don't advise for pumping. Instead, they need to learn to do hand expression of breast milk. Hand expression of breast milk is there everywhere in BPNA website. You can refer to the hand expression and you can do it. As a physiotherapist role, we know to assess whether it's a general engorgement or is the localized lump. So that differentiation, because of a muscle assessment, we're able to say it much better than other professionals. That's what I feel it so. And they should give with cold compressors instead of giving immediately with warm compressors. Whenever I go to hospital, we can see this warm bags will be there readily there. Whenever mother gets into engorgement, immediately they keep the warm compressors. The warm compressors will dilate the duct. Once the duct is getting dilated, you have to feed them immediately. But if you don't feed the baby immediately, again there'll be full gush of milk going and stacking there. Again, the engorgement will get aggravated to mastitis or other next abscess only. So make sure you first give cold compressors, and if it's still persisting, you can feed the baby for warm compressors for comfort. It should be alternate, not like one warm compressors alone. You shouldn't be continuing that sort. So when engorgement is not being seen at that point, the later stage will be happening is the milk duct. The milk duct, block duct, which happens is a particular duct alone is blocked. Few of the reasons are there. One is the braziers, wrong wearing of braziers, and next thing is one particular position. If a mother has been always using one particular position to feed the baby, automatically the other ducts are not being given the space to withdraw the milk completely. So still the stagnation of the milk will be happening. Third thing is latch position. The latch position has to be perfect so that they don't get into this. So when these 3 things have been corrected in the first 1 week of the childbirth period itself, there's no reason they'll get into this block test. But if this is not being addressed at that point, they are very high chances of going for mastitis and abscess. When they're going for mastitis and abscess, make a point that they are being referred to the primary caregiver, that is either to a physician or to the gynec, so that they have to start with the antibiotics at the earliest, so that they don't land up in the abscess. Instead, in case if they are born with abscess also, the earlier they go to a breast surgeon, they can do with a ultrasound guided needle aspiration. But if they're delaying for some more days, that may go with open IND surgery. So documentation by a physio. So yeah, the first thing is soap. Soap, usually you know everything by getting a history from the mother and from the caretaker. I feel from the caretaker also is equally important. For the initial days, mother will be only holding, but more handling will be done by the caretaker. So I tend to get the history of both of them. Then consultation by objectively, we tend to see how the baby is being placed, how she's holding the baby, how's the posture, and how's the breast in appearance. That's all we see. And assessment, we do have assessment skills, but generally when we assess directly, we tend to see the latch, the position, how the baby is sucking, whether the baby is able to swallow properly, and tend to see the oral assessment of the baby also. So there's something called tongue tie ankylosing. This is actually been missed in many of the hospitals. So in our visit, we make a point that all babies are being checked with ankylosing. In case if it's there, there's nothing to worry. Only thing they need to have some more deep latch. It's not to be so alarming as such. Only they need some more deep latch so that it doesn't interfere with the sucking pattern, and mother also doesn't complain with the nipple pain. And plan of action, they have to write a complete plan. What is the treatment they are given? That is the latch position, how they are corrected, how frequently they should feed. In case if a mother needs to have express breast milk and give it through a cup or a parladder should be advised. And what is a follow-up? That is, you're going to come after a week for a follow-up. Everything has to be communicated. So many breastfeeding assessment tools are there. One tool which I picked up for my study is a latch score, which I did it for my studies to assess these babies who've been induced during labor, how they are latching, and babies who have not been induced at the time of childbirth, how they are latching. And the score seems to be fantastic for the mothers who delivered without any induction. The babies latched really well compared to the mothers who've been induced. The reason is the oxytocin which they get induced at the time of labor makes the hormone so much desensitized. So immediately after delivery, the lactogenesis process is getting delayed. So that's the reason oxytocin desensitization has an impact in the time of the lactation period. So frequent sucking is only one key which can trigger up the milk production. So there are other scales. As I'm running out of time, I just want to scroll it up. This is a latch breastfeeding assessment tool, which we tend to fill it up. At the first day, we tend to fill up, and again, discharge day, we tend to fill up to see the comparison whether the mother and baby has improved with their bonding of breastfeeding. And this is what is a tongue tie, which I mentioned. There are about 4 types of ties are there. Whatever type, we can still breastfeed, but the option is open for the mother whether she wants to go with the tie release or not, where she can sit and talk with the pediatrician and also with the tongue tie specialist. And as the physio role comes all along from the girl. When the girl comes from the adolescent period, pre-pregnancy, pregnancy, post-pregnancy, physio role is eminent. You can't be without physio. That's what I feel it now. So lactation should be an add-on skill for all physios. It's not a profession separately. It should be an add-on skill. Everyone should know this lactation as a profession, because once you go for a postnatal round, so you're going to tell about this also. And this patient is going to come for you in the post-delivery days when they go and see the gynec, and they're going to come and check you also. At that point, again, you can reassure the lactation is going proper, the posture is going proper, and also you're going to address them about their post-delivery pains of the neck pain or shoulder pain or wrist pain. You're going to again go along with them. After a few months, you're going with your pelvic rehabilitation. So the connectivity actually grows. The connectivity grows from antenatal, childbirth, postnatal. It grows in a very longer period than anyone else, more than the gynec. Many times my patients will be spending more time and talking with me more than the gynec. So the interaction is becomes very open because we are spending very long time with them. By the time they're done with the first one, they come with the second childbirth also to us. So make sure physios get into this field, and also being in the part of labor is a very key thing for all physios. So scope of practice, there's no scope of practice as of now mentioned in Indian scenario. Okay, so it is our own ethical and professional policies. We have to take our own principles and take the scope of practice. The one main thing which I want to say is be truthful to your work. be evidence based, and be always coordinating with other medical staff. There's no independent work in medical field, it's always co-working with others. And make sure you maintain the privacy and confidentiality of each case, no discussing with others. And last one thing is free of conflict of interest. As already Professor Shanmugavela said, conflict of interest is there everywhere, so we have to be very vigilant to it. And who are the team members? The immediate team is your ops and gynec. For any kind of mother issues like mastitis or opsis, you have to make sure you call the gynec immediately and report to her personally. And second thing is the pediatrician. Having a rapport with the pediatrician is very important, because he finds it very comfortable to understand what's happening. Most pediatricians are male pediatricians, they doesn't know what's wrong with the mother. Immediately when the mother says, I don't have milk, I have a short nipple, he just believes so, and immediately he writes a formula. But actually when we see in person, there won't be any problem. Mother will be pouring out with milk and her nipples is not a problem at all for direct breastfeeding. So once we report this to the pediatrician, he'll be like, really good, you told me, I was thinking something else. So make sure you report all your cases to the immediate caregiver of the mother. Second is you need to have a team. So this team actually has to be a referral team for you, which you can take on your own decision. As an outpatient clinic, you can do it. First one is a breast surgeon. In case of slight kind of a lump, it's better to do an ultrasound to check any milk pockets are there, because for fibroids also there can be milk pockets will be there. Endocrinologist, why I had put endocrinologist here is we do induce lactation for adopted mothers and for mothers who go for surrogacy program. For the biological mothers, we do induce lactation. So endocrinologist's role to prescribe the medicine gets along with him in his team is actually good. And next is psychologist, psychiatrist is inevitable at this scenario. Most mothers land up in postnatal depression. So having a conversation with them antenatally during childbirth and postnatally, you can pick up really well what the mother is up to. So timely reference of this case to a psychologist actually saves many lives. That's what I need to say. There are sometimes I get call, ma'am, everyone are sleeping, my baby is crying, I don't know what to do, I'm doing something wrong to my baby, I feel like jumping out from my balcony. This is how they call. So it's actually scary. So this has to be addressed to the family members. So the counseling and education has to happen to the family members instead of concentrating only to the mothers. And nutritionists, actually nutrition is not my role, so I don't know how to prescribe the calories and all. So I leave it to the nutritionist to talk about the lactating foods and everything. And dentist, why dentist be here in Chennai, we have a dentist to do the tongue tie release. So I keep him in my team, so that in case of opinion base, we tend to send the mother to that to get again an opinion. And next is a general surgeon. Sometimes tongue tie release done by a dentist or a general surgeon. And in case if they have any kind of soft tissues release, they needs to be done, all kind of neck control, we tend to have a occupational therapist. And of course our NDT physiotherapist also is there. And there's some new field has come up, I could see this, a biodynamic craniocycle therapist, where they are starting to pitch into it. But I'm not sure about that field, but I tend to hear a lot from them also. So lactation preparation courses, which one I can do? The first thing everyone comes to say is, can I do IBCLC? Yes, even I have done IBCLC, but now when I think over, more than IBCLC, only with my practical experience, I was able to learn more. Because IBCLC is a Western concept, it's more of theory oriented. There's no practical training is being given. From Breastfeeding Promotion Network of India is a concern which gives both practical and theory knowledge. But one hempinch in this, there's no renewal system is there. So you will not be upgrading like the IBCLC, where every 5 years you need to write, every 5 years you have to prove that you have done so much work in your field. So that thing, they're still working on it. Hopefully we'll get it done by this year. And infant young child feed practice, it's there online itself, you get it. And next is my concern. We have been doing the second year, we are going to do with this clinical updates in Indian breastfeeding practice. Why I kept this word is, I want to focus only on my population. I want to focus only with my problem, because many problems are being addressed by outside. There's no need of nipple shield at all for my mothers. All my mothers will do very well without the shield. These shields are all been Western concept. That's what I picked up. So I thought of doing this conference last year only with Indian scenario, Indian specialists, Indian doctors. The outcome was amazing. So this year we made it like online. So those who want to join, you can please contact us anytime. And that's it. I think I exceeded. I'm sorry, Purnima. You could have called me.
it's you're exceeding for 5-10 minutes is okay, because we can see your enormous experience in the work of women's health and lactation, and that experience matters. It is not the theory knowledge, as you said, because many of them stick to the certification. But it is, I always contribute the knowledge to the mother. Every mother you treat, she teaches you a lot. Thank you for the wonderful feedback and a lot of information you have given. And you see that 20 minutes is not sufficient when, as a physio, you want to talk about lactation. There are a few questions. There's one question which says that pediatricians tell the mother that the milk is not sufficient in the first few days. Hence, they need to feed the baby with top feed to prevent the baby from encountering jaundice. So, what's your
See,
view
I'll
on
give you one tip. I'll give you a very valuable tip. You just take it. You'll not believe that pediatrician will believe to whatever you say. Just give your time and energy for one case where you assist that mother every time with the breastfeeding. What happens is the baby will not turn out with any kind of jaundice, and the pediatrician will start to believe, okay, whatever he was thinking was wrong, he will start to believe. So only thing is we have to give our time and energy. Once we start to give that proof, every mother will feed, every mother will lactate. That's all. They will change. So only thing we have to give more of our time out of our role. If my role is being there only for 2 to 3 hours, for that case, for me to show no, you are wrong, I can't argue. I can't give evidence papers. Everyone knows, WHO, UNICEF, everyone says, but still why it's happening is they didn't have their own personal experience. Many times pediatrician themselves hasn't breastfed the babies, and their wives hasn't fed the babies. Maybe there should be so many other problems with them. But when they are bringing that to their outpatient, they tend to keep their experience also in mind when they talk. So they tend to say, you don't have milk initial days, you may not. But once we assess them and they see them, they're actually changing. Many have changed. So if you want to show that pediatrician, no, we can feed, you assist one mother and prove it to him, he will change.
Yes, I totally agree with what you say. You support one mom and she can be a lactation counselor for many other moms around. We may not be around, but this one person whom you have helped, definitely I have seen that she becomes the next lactation counselor. But I would also like to add one more point to this. If there is a thought that top feed can help in preventing jaundice, actually it is reverse. It is the breastfeed which starts from day one, that is within 24 hours of birth. If the mother starts, if the baby starts to latch, there is the neonatal or the physiological jaundice, which we are more concerned of. You see that in a matter of few days, the baby is off the symptoms. Whereas if the child from the breastfeed and you start to top feed, the jaundice basically takes a long time to get, the bilirubin takes a lot of time from the body to flush out. In fact, it gets reversed because the top feed interferes with the gut, the digestion. So it is basically the reverse. Even when the pediatrician says it is a breastfeed which reverses the neonatal jaundice, not the top feed. Thank you. And there's one more question where we are asking the research or evidence on mother's breastfeeding position and musculoskeletal dysfunction.
Yes, it's there. One study was there about ergonomic position and muscular dysfunction. Only one study, not major studies have come up. If someone is coming up, it's really nice, but not major. One or two studies are there. I do have data on that.
Yes, there are a couple of studies. What we see here is it is not the breastfeeding which is linked to the musculoskeletal, it's the position. So as a physio, you see a lot of studies have been done on musculoskeletal issues with dentists where you're using head to feed. So the same positioning we are using for the breastfeeding. So obviously, if you go with the ABP, it is positive to neck pain and to back pain because the person who is sitting for a long time, because breastfeeding is not a one-time affair, the lady will be doing it many times a day and for many days and for many months. So if you see a person who is inappropriately sitting, they do have a lot of back pain issues. And this is in par with the EBP for other reasons. We are sitting for a long time, maybe in front of computer or maybe breastfeeding. But the improper positioning leading to a direct link for musculoskeletal disorder is always is present. There is a lot of research, you all can look into it.
It would be
And
like repetitive strain injury.
sorry.
It would be like a repetitive strain injuries.
Yeah, it is basically RSI. So there is not much of research, maybe not tagged to the word breastfeeding position, but the research is there where it leads to a lot of musculoskeletal injuries. Thank you so much, Dr. Jayashree, for your inputs. Now we move on to the next speaker. We have Dr. Ruchi Jain, who's a physiotherapist with 15 years of clinical experience in the field of women's fitness and NDT pediatric physiotherapy. She's a co-owner of Jyoti Physiotherapy Clinic and mentor of Physio Yoga Fitness Center in Guna. She has worked with many hospitals and she has a vast experience in the field of handling the neonates. She will be talking about the topic feeding special child, challenges and solutions. Over to you, Dr. Ruchi.
Yeah, thank you, Dr. Purnima. Thank you, IAP, for giving this opportunity because this is something very, very, very challenging for us as NDT therapists because feeding special child means getting a special child is the main thing, main challenge facing a mother when a mother came to know that my child is a special one and उसके लिए accept करना उसकी family के लिए accept करना is a very difficult job. We as an entity therapist have to counsel them. So feeding special child faces many challenges and solutions are on our tips. If we focus on the patient or the child as a result oriented case, definitely we'll move on some better solution. So my content will cover up the feeding parts, importance of breastfeeding, challenges with special child and solutions. Feeding, what's feeding? It's only nurturing. It's a process of sucking until swallow reflex triggers. The main complication comes here. Feeding means for a new mom or a second mom, everyone thinks of feeding means just making the baby's tummy full. She never thought of feeding is something related to emotional, physical, mental, and moral development of your child. She is only concerned about is baby full or not, is baby had his or her nutrition or not. She is not pertaining about is your child connected to you, is your child near to you, is your child full up with you. So you have to counsel a mother. This is your baby, and you have to get connected with your baby. And feeding is the only way to connect with your baby. By feeding only, your child will understand that this is you who is taking care of. Now, breastfeeding benefits. Every one of us knew about all these things, but we will cover up some points. Breastfeeding as a mother, it lowers the risk of breast cancer. It lowers the risk of osteoporosis. For a child, it lessens chances of eczema, lessens pimples with smells after your diaper or your bumps of your baby. It protects against diarrhea and tummy upsets. It lowers risk of diabetes. It protects against chest infection and wheezing. It protects ear infection. It focuses on better mental development. It focuses on better mouth formation. And when we are talking about a special child, say a premature baby or a Down syndrome or a Turner syndrome or some syndromes or birth asphyxia cases, these childs already faces many challenges in their motor and emotional and physical development. And once they are weaned of feeding, once they are not with their mother in their initial life, they feel like deprived because mental and emotional development of a child begins at the age of 30 days of a child. Till the time, by the time of 30 days intrauterine, that child recognizes your touch, your feel, your body. And if you're not feeding and the child is away from you, he or she will think that I'm all alone. His mental and moral development will start sluggishing, and this will give a negative impact on his development later. Now, challenging feeding challenges we face with a special child, the main thing is psychosocial acceptance because mother thinks of why this curse came to me, why this happened to me, that I have this a special child. Family, at times, family gives a taboo because of you, because of your habits. This happened to me. This is your family background. This is my family background. And all these things happen with a new mom. And As Jayashree ma'am told, oxytocin is the most important thing to uh, improve feeding part. But oxytocin is released when a mother is relaxed. And when you stress a mother, how will the oxytocin release, right? So you have to counsel the family. You have to counsel the mother that this is your child and it is you who can make your child grow very well. Got it? So a feeling of depression once mother and family knew about congenital or birth anomalies, feeling of insecurity and end of life. It happened with one of my patients. That lady was not prepared for the delivery part, and the baby happened at exactly 9 months of her delivery, and that was a premature baby at 8 months. Kept in ventilator for some 20-25 days, and the lady thought of that why this curse happened to me. I never liked babies, and this baby is special to me. So she kept the baby off from her for 2 months. And this was the time baby went into depression. After that, we started off with the kangaroo techniques, skin to skin contact. And after 2 years of hard work, the baby became normal. So that was the best thing. Baby came normal because here the counseling of mother was the best part, was the most important part to come up. Now, coming up the physical challenges, infants with CP presents with weak suck and tiresome. Already they are physically weak, they are morally weak, they have some asphyxia issues, so they have weak sucking reflex, and at the same time they have weak respiration, and because of that they tire. Infant with spastic CP, they present with spastic bite. What is spastic bite? That a strong involuntary bite which is difficult to release. That is difficult to release. It's very easy to overcome this, as Jayashree ma'am told, to teach the mother for a deep latch. If you will activate sucking and rooting reflex of your child, we'll be talking about later in this schedule. And once you make your child for a deep latch position during feed, you can downfall the spastic bite episodes. Flaccid CP presents with excessive drooling and dribbling because of their poor lip closure and lack of coordination. The lip part is a weaker one, and they can't seal their lips, and because of that, drooling and dribbling happens. And at times, this is the thing: the mother feels ashamed at the psychosocial level, and they don't feel like the child is mine, and they are not ready to accept the child as they are. Athetoid CP, they have discoordinated oral movements. And the main challenge while we face with these is our aspiration. Because of this weak and uncoordinated respiration, aspiration of fluid is common, which results in immediate coughing or dribbling of the fluids outside, vomit in our layman language we call about vomit, and later aspiration pneumonia, which can result in death at times. So to overcome aspiration, cross-cradle feeding position, what Jayashree ma'am told at present is a very good one. This can minimize the chances of aspiration pneumonia, and we can save our baby. As physically, babies present with weak sucking and rooting reflex, their swallow reflex is sluggish and delayed, and gag reflex is also hypo and hypersensitive. Now talking about the solution, counseling of mother and family is the most important part. Once mother is ready to accept the child and tie up her mind that I have to make my child a near normal one or a normal one, of course that baby will grow. Okay, this is the mother who is the only what you call dhal, only protective shield of your child to make your child a normal one. The first case, I was just doing my degrees in NIMHANS, and that time I was presented with a case, some 6 months baby with a Noonan syndrome. That time, that parents went to AIMS, and some pediatrician they told just leave the baby. He is presented with Noonan syndrome, which is a worse format of Down syndrome, and your baby will never recover, and you have to just seva karo uski, like. And the mother was very disappointed. They came to me and I said, I don't know what will happen. Just start with the work. And today, that baby is 16 years old, studying in 10th standard. with a near normal life. He's not normal. I will not say he's normal because he has that all Noonan syndrome clinical presentation. But her mother once decided, I will make my baby normal. I want to make my child's life a good one. So she just make the day and night equal, and just she worked hard. Whatever I used to guide him, whatever I used to instruct her for the development of her baby, she did, and today that baby is near normal. So counseling of mother and family is very important. You have to make the mother realize that you can make your baby near normal. So don't stress, don't feel down. You can make it. Kangaroo technique is skin to skin contact. You have to keep baby maximum on your right side, the max you can. By the time, look, that I have a baby with me, if I can keep the baby with me on right side, the baby will have a feel I'm with my mother. This way, you can make your baby feel that she is inside your womb, inside your uterus, inside the, this is the maximum protected area the baby can feel. So this is called a kangaroo technique, maximum skin to skin contact for maximum duration. At many times, old person suggests to tie a band around your body with your baby so that baby is connected with you for max. This is kangaroo technique. This is very good and very amazing for especially kids with special demands. Oral activation technique, this is the magic of physiotherapists where we can improve the feeding habits of child. Now coming about positioning, Jayashree ma'am told it very nicely, so no need to start up here again. Just a brief, comfortable for mom, keep your back straight and supported, keep lap flat, keep extra pillows. Positioning should be comfortable for child too. It should help close to you. Baby's head, shoulders, and body must be straight in line, or neck can be extended to avoid aspiration. Baby should be turned to mommy, nipple to nose, and baby to wrist. All these things Jayashree ma'am told. Now we'll just straight move forward to oral stimulation program. During oral, this stimulation program is developed by Cecile et al. And Coy et al. Some 20 years back, I guess. It focuses on lips, cheeks, and tongue. Lips, cheeks, and tongue, we need to focus to improve the range of motion, improve strength, swallowing, lip closure, sucking, and activation of palate. Now we'll learn what are the techniques. Just keep on looking here. First technique is place index finger at the base of nose. Okay, this is base of nose, you can see, and compress the tissue. Move finger towards the ear and then down towards the corner of lip in a C pattern. I repeat, move your finger towards the ear and down again in a pattern of C. In this way, we will stimulate the range of motion and strength of cheeks and lip seal. This is very good for flaccid CP. To make the lips seal, we have to stimulate the oral part. So we will move the finger towards index finger towards the ear and make it down in a C pattern. In a second technique, place index finger at the corner of lip, compress the tissue, and make a small circles on the upper lip movement. Small circles till the center and till the upper end of the lip. Then repeat it in opposite direction. Got it? Place your index finger on the one corner, make small circles till the center of your lip, and then make it back, make it till the other corner, and then repeat in the opposite direction. Same with lower lip. Place at the corner of lip, make a small circular pattern, and then till the center of the lip, till opposite corner, and reverse. Again, in this way, we will improve the lip range of motion and sealing, lip closure. This is important for holding the latch, which is one of the challenge while feeding this special kids. Now, as a third position, place index finger at the center of upper lip, stretch towards midline. You can see the nose and lip has a midline. Everyone has this one midline. So just place the index finger at upper corner, center of upper lip, stretch towards upper midline for 2 to 3 seconds, then relax. Repeat with lower lip, Keep your index finger at the midline, stretch towards midline, make a gentle pressure, keep for 2 to 3 seconds, then you can relax. Okay? In this way again, we will improve the lip strength, range of motion and lip closure, which is again important for holding the latch. Now, we'll talk about the activation of gums. So you can see we have a gum here. Place finger at the center of gum. With a firm pressure, take your finger towards the back of mouth, then return to the center, make it to the opposite hand, and return to the center. Okay, I repeat. Just one more thing, I just forgot to tell you, keep your hand hygiene maintained because these patients are very prone to infection. So keep your hand hygiene maintained, wash your hand with a nice soap that is in a warm water, dry it properly, use it, or you can use that finger brush. Silicone finger brushes are available in the market. You can put on brush on your finger, then you can do it very smoothly and nicely. That won't hurt your child. So again, I repeat the fourth technique. Place finger at the center of your lip, center of your gum. Move it slowly towards the end, then reverse. Move to the opposite direction and then reverse. Okay, then we can repeat it with the lower gum and then center of the gum till the opposite corner, then center again. Okay, in this way, we are going to improve the range of the gum sensitivity. This will help to hold the latch. This will help in improve of sucking reflex. One more, this is something developed by Fisil and Coy, but I used to do it for the inner gum too. From the past 15 years of my clinical practice, I'm repeating this for the inner side of the gum. I used to place my index finger at the inner aspect of the gum and make small circles. I start with the molar part. I used to make it till the center, till the opposite end, and reverse. Same for the lower aspect. Keep your index finger at your molar part. You can make small circles, concentric circles like a jalebi, and you keep on moving till the center and till the opposite end. Believe me, this is very amazing. Once you started doing, the child will improve tremendously in sucking and rooting reflex. Okay, so this was sensitizing gum and improving the range of motion for lips and tongue. Now the other part is this we'll be doing at the outer aspect. Place your finger on a corner of the lip, compress, move towards molar and back. This you have to do when the child's mouth is closed. Just put your finger inside the lip part, move towards the gum and then reverse. Then opposite direction, then reverse. Okay? This way, again, we will facilitate the latch holding, sucking and rooting reflex. And now place fingers at level of molars between the side blade of the tongue, somewhere here, and you have to press the tongue towards center line. You can see you have to keep your finger. Suppose a tongue is here. I don't have a tongue here. Suppose a tongue is here. Just keep your finger at the side of the tongue. Start pressing towards the midline and towards the border of the tongue, across the border of the tongue. In this way, you will stimulate the tongue to hold and range of motion and strength of the tongue will increase. Okay, so these are something oral stimulation techniques we can do to improve sucking, improve lip closure, improve swallowing, improve strength of lips, cheeks and tongue, and range of motion of all three objects. Fine. Now, two important techniques to stimulate instant sucking. One is very easy. Just stroke on the upper palate. If a child is having a mild CP or mild presentation of asphyxia, he or she will cope up immediately. Just with your index finger, stroke on the upper hard palate, child will stimulate with a sucking reflex. If your child is having a major problem or a deep problem, then you have to do it two ways. Just hold hard at the hard palate for 3 seconds, count for 3, immediately compress center of the tongue for 3 seconds and move ahead. Repeat this process some 3 to 4 times. Got it? 3-second compression of hard palate, 3-second compression of the center of the tongue, and again move ahead. In this way, we will stimulate the sucking reflex of the child and hence will stimulate the feeding. Now, when you think your child has aspired, when a mother complains of your child is always coughs after feeding, always expels the fluid, you have to teach how you have to position the child. While feeding, as Jayashree ma'am told, it should be slightly extended. After child, make sure your child takes a burp. Make your child vertical, neck extended, and pat on the back so that the fluid goes down and the child burps. If the child is burping, this activates the swallowing part. Swallow reflex is activated, and this will help in sucking and rooting of your child. And if a child expires and presents with cough, serious cough, then please refer for respiratory care. So here presenting with a summary, every child is special and special child needs special care for healthy survival, and trust yourself, trust your child, trust your therapist. If you trust that you are the one who can make your child better, of course, future of your child is best. Okay, over to you, Dr. Purnima.
Thank you so much, Dr. Ruchi. It was very enlightening presentation. Especially I liked your neat demonstration of oromotor stimulation, very much needed, because participants would really like to see something in demonstration rather than hearing, because we have a lot of content on online now. And your emphasis on these techniques improving the latch is very much true, because there are a lot of cases who come in where the mothers have challenges. Some have low palates, some have high palates, and some really don't have the NNS sucking. So to convert the non-nutritive suck to nutritive suck, we need to educate the mothers, and you very well demonstrated the oromotor stimulation. I would just like to look if participants have any specific questions. Yes, there are no any specific questions, but I would like to ask your inputs about how to feed a cleft lip versus a palate baby.
For cleft lip and versus palate baby, you have to check for how much deformity and deviations are there with your child, and you have to strengthen the lip and cheek part. And once you have strengthened and maintained the ROM, then you can easily do with that.
Okay, what position do you really recommend? Because what I feel, feeding a cleft lip is more easier, but it's very challenging
Cleft
to feed
palate,
a
yeah,
cleft
for
palate.
cleft palate. Right, right,
Especially if
right.
it
Agreed.
extends to the hard palate, to the soft palate, it becomes challenging. So how do you facilitate the breastfeeding position so that we don't have much of aspiration to the nose?
As Jayashree ma'am told, that cradle position and football position is the best one to feed the kids with cleft palate and cleft lip both. So in this way, aspiration won't be there, and spilling of the content won't be there. That will not deteriorate the mother part, and she will be comfortable in feeding the child for a longer time.
I'll just add on to it, no?
You
So
can add your inputs, Dr. Jayashree.
yeah, I think cross cradle, more than that, making the baby like sitting and feeding,
Yes.
literally like sitting and feeding, so that the aspiration doesn't happen. The cradle and cross cradle is still more not so easier. And also when you make the baby sit and feed, you can do much more deeper latch access to say in layman term, putting a burger and say the baby's stomach. So like the full mouth is full with breast. As you saying, if it's the soft palate or hard palate also, they'll not be able to sufficiently withdraw, but they could maintain really well. For sure they can maintain really well.
Yes, very rightfully said, because it is this positioning, keeping the baby's legs on your lap and holding the neck. This will actually prevent, not that this position will totally evade the milk, but this is a very, this is the best position which is advocated with the special
Yeah.
bottle, which can be used. Yeah, thank you both the speakers for your inputs. And I would just, before we wind up, I would like to welcome Dr. Ruchi Vashne here, our national head for the IIP Women's Cell. Please welcome, ma'am. And it's a pleasure to have you here. And she's also an IIP treasurer. I would like you to have some of your inputs for today's webinar so that our physios get some message.
Thank you, ma'am. Thank you for the invitation. I think there is one more question left. Somebody is asking for the milestone development. Purnima, ma'am, please check. There
Yeah.
is one
Yes.
question
Yes.
from a
Yes. We
participant.
will get back to it. I think you can address it. We will get back with the questions to the
No,
speakers.
that's okay. Uh,
Yes.
Thank you so much, Jayashree ma'am, to take the initiative. And I think I would like to tell everyone who's watching on YouTube and all the participants of this webinar and who will be watching after this is over, because I think most of the people are flying kites on the terrace. It's being Independence Day. So, but priorily, thank you to TN Forces to take this great initiative to celebrate this breastfeeding week. And they've been doing it for years together. They have tied up with so many organizations and done a wonderful work, because I think this care is the care which, you know, it's the of the utmost importance. हमारी नींव है ये हमारा, you know, it's the root and on which a good society, a good nation, a strong nation can be built up. I would like to thank our other speaker, senior sir, Shanmukh sir, and thank you, Jayashree ma'am. Thank you, Ruchi ma'am, for wonderful sharing of the knowledge. We were watching you on YouTube. Thank you, Purnima ma'am, to just, you know, rope in fast to share her experience with all of us, and it's wonderful. Personally, I feel this kind of work should be more, you know, there should be more encouragement, because women health is something which was like being ignored for many years. But with IAP Women Cell, we all started with this initiative to connect more and more women, to collaborate with them, to communicate with them, to sort out their queries, to give them the support that was needed before, and there was no one they could look up to. And therefore, the entire association, the Indian Association of Physiotherapists, came up with this idea of IAP Women Cell, because physiotherapy is priorly, you know, I call it a mother profession, because we
Right.
have more than 60% women in the profession. So we have been like privileged to get this stage, and we have been doing on this IAP India a lot of like webinars with the related to women health. And with this, I think we have entered into a new zone, and we'll be looking forward for much more activities in collaboration with TN Forces, with Jayashree ma'am, Ruchi ma'am, Purnima ma'am, and more, you know, international women speakers also. So thank you so much for the invitation, and it was great. And thank you for inviting me. Thank you so much.
I just
Thank you.
add on to the note to it. It's and I thank you, Dr. Ruchi. It was so warm. I've been not with IAP for so many years. Even I've been physiotherapist, member of IAP. I've been very far from them. I don't know why I feel it now. So I feel so like being at home. So I
Because
was
you didn't have a dynamic team. That is why.
Well said, Purnima ma'am. That is very well said.
yeah. So she organized so well. She made it everything so well organized. So I need to thank. I think we need to pitch in more onto birthing also, because everything starts from birthing. So if you could have some more inputs, having labor exercise specialist as a term I've coined for all physios. I don't want to have another term to be used. So I placed it like a labor exercise specialist for physios to be there throughout the labor, assist labor, and immediately continue with the lactation also. So the bonding and the trust with the other medical team is also still more getting stronger. So we are bringing the whole team together. It's not only physio community alone. I'm talking as the whole medical team.
Right. Yes,
Right.
that's right. I was looking for like for what all work you have done in the past, and it's great that you have connected all the like pura backbone bana rakha hai for the women health, like being pediatrician, gynecologist. We have connected to so many, you know, other medical fraternity, and that is great. As a physio, I think we need to connect with all the medical specialties and make sure that we are connected with them this will yield results, because I think it is just it is lacking from our side, that we have not been able to connect with these people, because everybody is
Very
ready to
true.
accept us. It's just that we've been suffering from some inferiority complex, I think, for so many years, but now it is high time we should come up as a very strong team, and we are looking forward for much more collaborations with you
Hope
and
I'll join IAP family also. Let me look into that
most
also.
welcome. On behalf of entire IPCC, our president Sanjeev Jha sir, our secretary Annamalai sir, our vice president Reddy sir, and entire CC, we all are thankful to TN Forces and Jayashree ma'am and Shanmugh sir and entire team. Thank you, and please keep on doing the good work
Thank you.
Thank
and
you.
make
Thank you.
us
Thank
proud
you
of you.
so much.
Thank you so much,
Thank you
ma'am.
so much. Thank
Personally,
you.
my concern to Dr. Ruchi Vashne, we have known that we know the more than 50% we are women. And over the past 20 years, since the time I have joined working, I really feel sorry that we are still in a snail pace when it comes to women's health physiotherapy. And I guess we should start advocating our work, because I always feel that is the only barrier. It's not that the doctors won't accept, but what the physios, what the freshers think is, when you're sitting there, when you finish your degree, people should just offer you a job. No, you need to go out, tell what you're doing. Yes, it takes some effort. So you start doing it, because I see a lot of our postgraduate students and all, they are really doing good job in some parts of India, but not everywhere. So I want our IIP cell to start up some, just assistance, where sometimes people might be having some challenges where they think, will I get a job or no? They just need somebody to, push them. So maybe we can just, through all such good activities, maybe we can let
Right.
them understand that we
And
can grow.
we are soon coming up with IAP NRI cell, because recently I would like to mention that we have entered back into WCPT, now called as WP, Word Physiotherapy.
That's
And very soon we'll be celebrating Word Physiotherapy Day after years of, now we are readmitted, and that's a proud moment for all the Indians. I think it is high time now we have to be representing in each and every, branch of Word Physiotherapy: aquatic, women health, cancer, pediatrics, geriatric, all the branches. And women health is something which Indians, I feel, will be much better placed once we enter inside. So now we are in WP, so it's like we'll enter other zones also.
So let's
Yes,
hope that we
definitely.
will make it. Thank you so much, everyone, again. So
Thank you so much.
before we wind up, we will just answer this other one more question, where they're asking any special suggestions for a baby with hydrocephalus. The baby has undergone VP shunt. So what are the suggestions? I think Dr. Ruchi can throw a light, and maybe even Dr. Jayashree can pitch in.
Yes, for hydrocephalus and the patient underwent VP shunt, their reflexes are more sluggish. So it's very difficult to activate reflexes there. Of course, it depends on the age part too. If the baby is at the feeding age, you can't make child depend on breastfeed, because he or she can't, because of the VP shunt reflexes are not there, and you have to go for the top feed. But if a child is more than a year, you have to make that NG tubes or some tubal feed you have to enter with.
Okay.
We have seen hydrocephalus cases, like Ruchi mentioning. It's difficult only because the baby will be in medications, it will be drowsy. So we tell them to express breast milk and give it through pallada. So that's what we use it here. So pallada is a small container with another end is like a snook. So that through that they'll tend to feed the baby. But if the baby is very sluggish, they need to have a tube feedings. The long prognosis of it, it depends upon how far the baby comes up based on that only. But during the NICU visit, most of the time it's been said to be like express breast milk and feeding.
Thank you so much. I really thank all the participants for giving their time, and I hope you all had a wonderful session with the speakers. And the email addresses are also given at the end of their presentation, so you all can get back to them if you have any personal queries. And being a physio, breastfeeding is not actually a part of a physiotherapy curriculum, but what we understand here is that we so much can be a part of it, and there is so much to learn. What you all are getting to know is just the tip of iceberg today. And if you start reading lactation, it is really equivalent to your master's. so much of depth in knowledge is there for lactation. So you all
Right.
can look into the slides which Jayshree ma'am has rightly put up, the websites. There are a lot of education materials. You don't have to be an IBCLC directly. There are a lot of materials which suit the Indian population, and you all can, people who are already working with women's health hospital can start right away with many simple courses, and of course there are all these people, and you can be in touch with them. So I wish all the physiotherapists good luck, and do more in women's health. Thank you once again.
Thank you, everyone.
For the wonderful
On
Thank you,
behalf of
everyone.
On behalf of IAP technical team, thank you so much all speakers for sharing your knowledge. Also thankful to audience who make it this webinar successful. Last but not the least, by my big thanks extend towards our IAP President Dr. Jha sir and our IAP Women's Cell National Head Dr. Ruchi ma'am. And also thank you ma'am for your give your valuable time. Before end this webinar, I request to all participants please subscribe our IAP YouTube channel for watching more and more webinar and for knowing more and more knowledge. Thank you.
Thank you, everyone.
Thank you.
Thank you, everyone.
Thank you. Bye.